Whenever a red eye comes to the OPD, we normally have some of the common differential diagnosis. It could be a viral conjunctivitis, uveitis, endophthalmitis, or phacolytic glaucoma. So today's topic of mine is to handling a phacolytic glaucoma in the emergency clinic. So in such conditions, patients normally present with vision that is less than hand movements with the raised IOP of more than 30 to 40 millimeter mercury, and they present with circumciliary congestion, corneal edema. AC cells and flares can be identified in case the cornea is not cloudy, a mid-dilated pupil as well as a white mature cataract. So once we come into conclusion that this is a lens-induced glaucoma, some of the other causes for raised IOP should also be kept in mind, and that could be a uveitic open angle glaucoma, acute angle closure glaucoma, glaucoma secondary to trauma, or a neovascular glaucoma. In case of uveitis, definitely we are going to find keratic precipitates. The list of causes for acute angle closure has already been mentioned previously. In neovascular glaucoma, it is very important to notice the new vessels seen in the iris or at the angle, and history of trauma also helps us to aid towards glaucoma secondary to trauma. Now coming to lens-induced glaucoma, there are three types. The phacomorphic, which actually causes secondary angle closure glaucoma because of the forward pushing of the lens that causes the narrowing of the angle and obstruction of the outflow of the aqueous. Then we have the phacoantigenic, which is previously called as phacoanaphylactic, where the lens itself's own antigens act as a immune complex, and this could be following a surgery or a penetrating trauma causing obstructions to the trabecular meshwork and open angle glaucoma. So this is mainly an immunocomplex reaction. And finally, the topic as discussed, the phacolytic glaucoma, where there is leaking of protein material from a hypermature cataract causing trabecular meshwork blockage, leading to inflammatory glaucoma. So the ultimate management in such condition is basically lens extraction and an IOP control. So pre-operatively, before taking up the patient for surgery, we need to start the patient on oral anti-glaucoma agents like IV mannitol and tablet acetazolamide after confirming that the patient is not allergic to these medicines. Topical anti-glaucoma, prostaglandin and analogs have to be avoided as this is an inflammatory condition. And it is always better to start topical anti-inflammatory because it will bring down post-op inflammation. A detailed history of systemic comorbidities has to be taken, as we cannot immediately take the patient for surgery if he is a very high hypertensive patient, uncontrolled diabetic. In such conditions, we may have to wait for some days before taking up for surgery. So coming to the ideal intraoperative surgical technique, we have the ECC, which unfortunately gives us a large incision causing an expulsive choroidal hemorrhage following sudden decompression. And then we also have a phaco, but in this case, because it's a shallow AC and an edematous cornea, the chances of post-op edema, the increased risk of endothelial cell loss, and poor view is some of the challenges faced. So ideally in these conditions, going with a small incision cataract surgery is always safe and effective. Now coming to the intraoperative challenges that is faced in any of these procedures, firstly, the view is going to be very hazy because of the corneal edema. Secondly, a shallow AC in a phacomorphic, or if in cases of such case, the instrument manipulation becomes difficult. Pupil dilation, again, it could be a mid-dilated pupil or a pupil with posterior synechiae. Again, this is going to hamper the dilation and the smoothing of the surgery. And last but not least, because of the chronicity, we can also face with a fibrosed capsule, and hence achieving an ideal rhexis becomes a problem. So here is a video. Yes. So this is a video of an IC86 surgery. So as you can see, the view is totally compromised. So in such conditions, you can also see that there is lens particles along the angles in this patient. So here a 5 mm, after putting the superior rectus, a 5 mm incision is done, as most of the time in hypermature cataract, the nucleus is going to be very small. So after completely thoroughly giving an AC wash, we see that the view is pretty clear. An ideal rhexis is achieved. After that, after using a good amount of visco, the lens is brought into the anterior chamber and then extracted. Now extraction can be done by visco expression or in a sandwich technique, whichever is comfortable and suitable. Care should be taken that the AC depth should be maintained so that we do not cause any capsular back dialysis or a PC rent. So as you can see, the result is good. Cornea is edematous because of the IOP, raised IOP, which following a couple of months has cleared. So in the hands of the expert, even phaco can work very well. But there are some very important challenges that are faced at the time of phaco. So in this case, there is a fibrosed capsule in this area. So attaining a proper rhexis becomes difficult in this scenario. So here the Uttrata or the rhexis forceps and scissors can be used to get an adequate rhexis. So once this is done, we go in for a phacosurgery. So the challenges faced during phaco is that the absence of posterior subcapsular plate as well as cortical matter. So normally the nucleus will be wobbly in nature and the high chances of catching the posterior capsule during the procedure. Once the initial crack is created, where a lot of care has to be taken to maintain the chamber in an adequate depth so that the posterior capsule does not come into the phaco probe. And the last piece removal is a very important step because there is no support posteriorly. So once this is done, a thorough AC wash has to be done in a manual or a coaxial method, and then a lens can be placed. So some of the challenges as mentioned are posterior capsular rupture in either of the condition. More commonly it is faced in a phacosurgery. Zonular dialysis if the cataract has been sitting for a very, very long time. Loose capsular bag. Most of the time in such conditions, if you are not taking adequate care, the lens may be got out along with the capsular bag. And occasionally we may see the phacolytic particles in the vitreous also, and in such conditions it can be managed conservatively. So coming to post-operative follow, it is not done with just operating the patient and giving him ideal results. Normally there is a persistent inflammation for which steroids has to be given until the inflammation is controlled. Then if there is a cystoid macular edema, these patients should be given on a long-term NSAIDs along with the close follow-up by the retina consultants. And also in case of a persistent rise in IOP, anti-glaucoma medications have to be given to these patients. Some of the complications because of the loss of follow-up or late follow-up is that a permanent damage to the optic nerve or a permanent corneal decompensation, which then leads to an endothelial transplant in such cases. Now, most of the common questions that is there in these conditions, do we go for a combined procedure with phaco plus management of IOP with trabeculectomy or no? But the general consensus is to manage the cataract by surgery and manage the intraocular pressure by giving anti-glaucoma medications, because in these conditions, inflammation is there and there are high chances that the trabeculectomy may fail. Thank you very much.